Okay, let's start. Well, welcome to this session on bone sarcomas. Bone sarcomas are 8 to 10-fold less common than soft tissue sarcomas, and they account for less than 0.2% of malignant neoplasm across all ages. Given their rarity and their difficulty, their complexity, they pose particular challenges to all those are interested. First and foremost, to patients whose needs are still highly unmet needs. Osteosarcoma, Ewing sarcoma, chordoma, chondrosarcoma, just to recall the most common types of bone sarcomas. Different diseases, but common concerns. Concerns that range from late diagnosis to lack of research, from limited treatment options, despite some advances in the last few years, to the late effects of treatments to the quality of life. Currently, the bone sarcoma community is composed mainly by groups or organizations focused on a specific type of bone sarcoma. And this makes it difficult to amplify the voice of all bone sarcoma patients and to implement collaborations among them more effectively. The good news is that under the umbrella of SPAGN, the Bone Sarcoma Alliance is taking shape in these last weeks, with the aim of bringing together patients and patient advocates from the different bone sarcoma communities in order to learn from each other, in order to collaborate more effectively, and to better engage with clinicians or researchers in areas of common interest. The idea is that of continue working in our patient communities for those areas which are disease-specific, such as Foster or Ewing Consortium or Condorma Foundation and the others, as well as in common areas of interest for all bone sarcoma communities. The kickoff meeting will be held shortly. And everyone who is interested to be involved, please contact us. You are very, very welcome. And now I'm delighted to introduce our speakers, starting with Professor Rinette van der Graaf. She needs no further presentation. The second speaker will be Dr. Emanuela Palmerini. She's a medical oncologist at the Istituto Rizzoli from Bologna. She's co-chair of the European Consortium Foster, and she specializes in musculoskeletal tumors. The other speaker is Dr. Jasmine Huber. She's a patient engagement manager at Myrovalitis, is correct the pronunciation, Myrovalitis Trust from London. And now it's my pleasure to welcome Professor Rinette with the first presentation.
There are moments in your life that you think, and that was when I was seeing that this all has to fit in the bone sarcoma session, because I thought I was asked to speak about adolescents and young adults with sarcomas in general. So I prepared something on soft tissue sarcomas as well. I'm sorry for that. That I thought was requested from me. But I will give some bone touch wherever I can, and I'm delighted that I have very good speakers after me who will really, I promise you, speak about bone sarcomas only. The question was to focus on young people with sarcomas, and in general, we internationally the definition of AYA, adolescents and young adults, is now 15 to 39 years at diagnosis. And they face special issues, and one of those, I will address with you. When we speak about sarcomas of AYA-age, it's not a small group, and I will show you it here. Sarcomas of childhood, there are 8% of the pediatric population that has tumors of soft tissue and bone, and they are the biggest group in total after brain tumors as a solid tumor in children. Over the age of 40 years, it's only, as you know, 1 or 2% of all tumors that comprise of sarcomas, both bone and soft tissue, where soft tissue is more prevalent than bone. And we looked at the incidence of tumors at AYA age in the Netherlands, so patients between 20 and 39 years at diagnosis. And here you have the results of the male bone group. And if you look at the black part on bone sarcoma, it's only 2% of the patients at AYA age. And that's even smaller than the soft tissue sarcomas, they are 3%. So in total, 5% of the males can present with a sarcoma. So although it's more often than in adults, it's still a small group, which comes with really challenges. In female, it's about the same. Bone sarcomas even less because there are so many breast cancer patients in this age group, and soft tissue sarcomas 2%. But again, it underscores how difficult it is for doctors to see these patients and to build up experience with them. Cancer is a leading cause at AYA age, and especially sarcomas, because they are really a challenging group at this age. And what do we see as challenging problems? One of the issues is delay in diagnosis, and I can just illustrate it with a patient, she had in the end a soft tissue sarcoma of the extremities, but who came into my office last week as a new patient, and she told me that she had already complained since the summer of last year, August. She went for the first time to her GP, and then in total, she went 6 times to her GP, who once sent her for an evaluation on thrombosis, which she did not have. She went to physio, didn't help. And she said, I think I have a swelling also in my leg. It's not only painful, but it's really not good. And then it ended up with a kind of pain crisis on the 31st of December, when finally, through an A&E, she came into the hospital. Then they did the further research, and she turned out to have a huge soft tissue sarcoma of 13 centimeters of her leg, right upper leg. And then she was referred to another hospital, biopsy, etc. So it took until February, end of February, before she started any treatment. And she told me that again and again, she heard wherever she was, this can't be serious because you are young. And I think this is classical for this age group, that they are not taken seriously. This is the same for bone sarcomas. Patients come there, are sent to physios, or you have a hernia or whatever. There's always a kind of thing, well, if you really listen to patients, then you think, why should this patient come again to me with the same complaint? So then there are other issues for young adult sarcoma patients. In contrast to pediatric oncology, where the care and research is more centralized, not ideally everywhere, but much better than in the big hospitals where all kinds of patients come, and where the whole group of AYA is only 5% of the total adult oncology population. Dus even when you pass the GP scene, I would say, then you come into a hospital and you're also one of the many, and not getting the care, if there is no specific care for AYA care, that is adjusted to your specific needs at your age. Then trials, there are not many, and there is also low trial participation in general because patients have to travel, they are studying, having work, having a young family, all kinds of reasons that make it more challenging for trial participation. There's a difficulty in new drugs for sarcoma in general, also for the tumors occurring at this age. And there's a lack of peer groups, so patients like me, whom they really would like to speak, it's difficult for them to find them. So what are the sarcomas of AYA age? We see Ewing's, osteosarcomas, especially in the younger group, also rhabdomyosarcomas. And when we move on, AYAs of 20 to 35, we still see Ewing sarcoma, osteo and rhabdos, but also other tumor types, as you can see here. And at older age, we see a lot of soft tissue sarcomas, if you compare it with the bone sarcomas, although then you have more chondrosarcomas that come, and also osteosarcomas, but then we also see a change in the incidence of osteosarcomas, because osteosarcomas of the extremities at a certain moment in time tend to drop in incidence, and you can have osteosarcomas of the jaw, which in fact is a totally different tumor, we think, than osteosarcomas of the extremities. And there's a lot of debate for osteosarcomas in elderly of the jaw, how to treat them. The only exception I would like to make is that I am also seeing patients with what we call the Li-Fraumeni syndrome, so the TP53 mutation in your germline. And these patients, I have already seen 5 of those with an osteosarcoma of the jaw, and they were all in their early 20s. So there's something very special with this kind of osteosarcoma. We also did a survey that was together with Roger at that time, where we looked at a national survey that was performed under all patients with sarcoma. Which of the sarcoma patients did worse or better in their experience? And here you can see we divided the groups of this survey in adolescents and young adults, in middle-aged and in elderly. And we looked at soft tissue versus bone, and we looked, of course, at also things like response rates, which were in total of this whole group, 75% of patients with a soft tissue and 25% of patients with bone sarcoma who responded to this survey. And what we saw in general, that patients with a sarcoma type in general have to wait long before they are referred or having had their diagnosis. And that's something common we see in rare cancers. But you see that the group who has a sarcoma but also is young, they really had more problems than another because they were first treated for another condition like the patient I mentioned today. So they are denied that their symptoms are taken serious, and that's something, well, a story you hear again and again. So delay in diagnosis is really an issue. And to be honest, you can't complain about GPs who only see 1 or 2 of these patients in their whole career. The only thing is that you can complain about is if the patients come back with the same symptoms again and again, then there is something wrong. So refer them and do additional research and investigations to see what's wrong there. We also did a survivorship study in the Netherlands, what we call the SURFSAC study. I briefly mentioned it in my previous talk, in patients who survived a sarcoma, as you can see here. And we looked at patients on all age and location. And again, we saw that sarcoma and its treatment had a greater impact on health-related quality of life on the younger survivors than on the older ones. They were doing worse on emotional cognitive function, and the patients with a bone sarcoma, important for this session, did really worse, and also in general they received chemotherapy. So this is a group really having the lowest, by far the lowest quality of life of all the patients in this survivorship study, the young patients with bone sarcomas. So here are the distributions, I mentioned them already, and the treatments. It's also interesting to consider that depending on your age, the treatments can differ. So pediatric oncologists are used to give chemotherapy to almost all their sarcoma patients. It's interesting when you discuss it with them, they are used to treat with chemotherapy because it's, I would say, in their genes almost. And that's interesting when you talk about less, where the treatment is less well established, whether you have to do it, then you get interesting conversations. For Ewings and Osteos, that's really established, the chemotherapy, and that holds also for young adults. The adult approach is more and more, depending on which kind of tumor sarcoma you have, is more surgery and radiotherapy, and then whether you need to add adjuvant chemotherapy really depends on your subtype. So I prepared something on soft tissue sarcomas, and I think it's hopefully still a bit worthwhile. I will go through it a bit rapidly. I divided my talk in 3 different tumor types: the real pediatric tumor occurring at AYA age, or the typical tumor of AYA age, like synovial sarcomas, which has a peak incidence at 38 years, or the patients who in general present at an older age, like GIST, who in general present at a median age of 65. But this young AYA group, is that a distinct group? What is this for kind of group to have already such a tumor at a young age? There's also another interesting thing ongoing. Patients with sarcomas of AYA age, this does not hold for osteosarcoma, but for Ewings and Ewing-likes often have what we call gene fusions. So there are 2 genes in the tumor that fuse together and that are characteristic of a certain diagnosis. And now I would like to tell another story of one of my patients, because with all the molecular diagnostics involved nowadays, we also see more and more fusions that we don't understand. And that also is the whole Ewing's family of tumor. There we see it, but it's for many, many other also soft tissue sarcomas that we get results and that we think, what does that mean? And the story I will tell you is just an illustration of where you can take just the really wrong route to treatment because you don't take the whole story into account. The patient was referred to me as a second opinion, 25-year-old young female. She was diagnosed with a lump in her elbow region, soft tissue one, and this one was biopsied, and then they thought about a benign tumor, were not sure, then it was removed like a benign tumor, so with limited margins, R1 resection as we call it. And then her tissue was again sent for further molecular diagnostics in collaboration with the pediatric oncologist. They found a certain fusion, a new one, not on this list, where the pediatric oncologist said, whoa, that's really related to rhabdomyosarcoma, and they went all down that route. So she was worked up for rhabdomyosarcoma, had a PET scan that was negative, no metastatic disease, and she was due to have 9 adjuvant courses of chemotherapy alongside the treatment of rhabdomyosarcoma of pediatric age. And then, so she went for ovary preservation and etc. And then she came to me and said, well, I still want to know, what would you do? Because it's such a rare thing. It only occurs in very young children. Why should I have this? Is this all okay? And when talking with her and with her mother, then it turned out that this lump was already sitting there, or first only painful thing, at least 12 years. So I thought, well, I know a lot of rhabdomyosarcoma patients, but to have one already for 12 years and then... So we went back to the whole molecular thing, and the literature, asked the pathologist to review, asked my colleagues overseas, And then in the end, it turned out to be a myofibroblastic tumor with this fusion. And yes, this fusion was the same one as can occur in rhabdomyosarcomas of very young children. But it was a benign tumor because that was also her story. She had it already sitting there for 12 years, slowly, slowly growing. So in the end, we said, you don't need adjuvant chemotherapy. This is it. You have a benign diagnosis and that's it. No radiotherapy because the margins were not clear. We just wait and see. And that's, I would say, only one comment from my side. Yes, molecular diagnostics bring a lot of insight into the sarcoma field, but we hear their stories and put it into context, because otherwise we just go on a totally different route. And in this way, it was really a totally change of diagnosis and treatment. So for rhabdomyosarcoma, that's a very difficult disease. It doesn't occur very, you can see here the incidence is very, very low at AYA age. If you look at it, they did a very nice overview of all sarcomas in the United States, and only 3% of adults had rhabdomyosarcomas. And in general, they have already met diagnosis in 30%, so that's really high. And you can also see here for the anatomic side, we do see more of these tumors in the head and neck region, relatively speaking, in contrast to other kinds of sarcomas. So it's an interesting tumor type. It's also a tumor type that gives a very high mortality. So if you have a rhabdomyosarcoma at AYA age, then in general, it's very hard to cure these patients, I must say. You have different rhabdomyosarcomas, and there is also here, I will not go through it, but this is just to illustrate how difficult it is. It's rare. It occurs mainly at pediatric age, and we don't see it very often in adolescents, as you can see here. For we see more alveolar rhabdomyosarcomas, a subtype which we call now fusion-positive tumors, who present often already with metastatic disease. And yes, they can respond to chemo very well, but it also comes back very quickly. Pleomorphic rhabdomyosarcoma is more something of older age, and that was the diagnosis that the first patient I was speaking about with a delay of 6 months had in the end. That's really a very high-grade tumor, and that's also expressed because when she came to me, she had already metastatic disease, so she was diagnosed late, and she had her metastasis within 1 month of her local treatment. And then you have intraosseous rhabdomyosarcoma. That's also something not very well known, but you can have bone sarcomas, rhabdomyosarcomas. They often are in the skull in young adults, as you can see here. Well, the treatment, I will skip that for the interest of time. Then I go to synovial sarcomas. That's really a sarcoma of AYA age. But it's an interesting sarcoma. It's the only one that can occur at 6 months and also at 100 years of age. There's no sarcoma that has such an age spread. It can occur everywhere in the extremities, in the abdomen, in the head and neck region. If there is a diagnosis of synovial sarcoma patient, and people say that can't be the case because it's such an unusual location, well, I must say I've seen so many unusual locations that I'm not surprised anymore. So the question was, is there an influence of age on the outcome of these patients? Because it's very weird to have the same tumor across all age groups. So we looked at this and we divided a study we did with the Netherlands Cancer Registry in this way. Again, we had the AYAs, a bit different age group, 18 to 35 at that time. But anyway, you can see here the results. 3/4 presented with a localized disease of the patients we saw in this time frame. And there is, as you can see here, if you have metastatic disease, then that's really, you have a very poor prognosis. But we really wanted to look at the patients who only had disease without metastasis to have a good comparison about their outcome. And as you can see here, there's a huge difference according to age about the outcome of synovial sarcoma, which is very interesting because the diagnosis is in general confirmed molecularly because there are characteristic fusion genes involved. But independent of the stage, this is a sarcoma that, yes, it comes over all age groups, but it has a different prognosis. And here you see other risk factors involved, but still age is a very important one. As you can see here, in a multivariate analysis, we still saw that age is a very relevant factor there. So it's an independent prognostic factor for overall survival, and it couldn't be explained by different treatment modalities. And it also helps the pediatric oncologists who are always in the, what I said, like to give or tend to give chemotherapy. They also are more careful and very more reluctant to give chemotherapy to good risk synovial sarcomas at pediatric age. And at adolescent age, well, we have to deal also with metastatic disease, but it's a very, I would say, interesting but also challenging disease in this way. Well, we did this exercise. Interestingly, also in the UK, there was a same initiative to look not at age as a prognostic factor, and they totally found similar results as we did. So this is what I discussed, and then the last one is on GIST. GIST is a tumor, as I said, of elderly age. I have someone in the room who can correct me if I say something about GIST that is not correct, because John Trent is here as the expert in the room. You see here the median age, elderly tumor. These are the patients in front of us. You also have pediatric GIST. It's a very rare disease. It occurs mainly in female gastric location, and they have a very low number of mutations in KIT and PDGFR. So our question was, how do patients of adolescent and young adult age it? And we looked at the registry. At that time, there we had about 1,200 patients involved. How many of those had a GIST diagnosed between 80 and 39, and that were in the end 52 patients, so a very small number. And we were wondering whether they present with a pediatric-like, very low mutation part of number of in GIST, or whether they were really the more normal ones. And here you see it, we compared it with the older GIST patients, and we saw that there were relatively more patients, it's on the bottom, who had a small intestinal GIST than in elderly. And we also looked at mutation status. We didn't have it of everyone, but well, to our surprise, maybe we found still 70% of patients who had a KIT mutation and 6 a PDGFR. But all the rest were, as you can see here, related to very rare mutations or lack of it, I must say. So the conclusions were that they are rare and differ from older adults with GIST, but also differ from the real pediatric GIST. So where you will hear from Ewing sarcoma and osteosarcoma that the treatment is similar in children and AYAs, we see here that the disease is different in children and AYAs. What is the difference? Well, they had more often a small intestinal GIST. And interestingly, what we also found that they presented more in the acute setting. Again, emphasizing that nobody is thinking of a malignant disease in patients who have abdominal pain or anemia or whatever. We have not seen KIT and PDGFR mutation in a quarter of those. And what we also saw that they had a relatively favorable 5 years overall survival of 85%. So finally something to say in a positive way. So my conclusions on soft tissue sarcomas, but also on bone sarcomas at AYA, is there is often a delay in diagnosis. that you really need for the diagnosis the whole story and good pathologists and people experts in molecular biology. That are many diagnoses at this age, and they are often rare, and patients present with a delay. And it's not only the GP, we also see that there may be sometimes delay in the hospitals. Patients should be treated at expert centers like pediatric patients in a multidisciplinary team. And we really need to relate to sarcoma specialists who see these patients more often than maybe we do. So if we have sarcomas, also bone sarcomas, which is really a disease also of pediatric oncologists, we need to reach out to them and collaborate with them. And always think of late effects. So whatever treatment you start at this age, it's such an important age of life. Consider that they can have late effects for the rest of their life, secondary tumors, and that there may also be part of a rare cancer syndrome. So take the family history and send them to the clinical geneticist if you consider that there is an exceptional disease at a young age, and the family is also having some other diagnoses that are rare or unexpected. So that was the end of my talk. I hope you enjoyed it.
This is great presentation. Are there any questions?
Was often included for the young people when they got this osteosarcoma?
Sorry, I couldn't hear the first part.
You mentioned that for younger people, it could often be osteosarcoma in the bone, the cheekbone.
No, the osteosarcomas of the jaw are related to older patients. Okay. The only group where I saw this happening, and I don't know whether others in the room, my colleagues, have seen it, is osteosarcomas in this location at a younger age in the context of the TP53 mutation of the Li-Fraumeni syndrome. So these patients have a predisposition of getting cancer, and it's remarkable that only in this group of patients I saw osteosarcoma in the bone, and in 100 patients I had 5 of those. So this is something we have to see, I think, at a global level, whether it's just by chance that I saw them, but I think it's too many to be by chance in such a very rare condition.
Okay, my question was, is the dentist involved in this? I think that it's a different group from the doctors. Are they familiar with this disease, so they can...
I think that dentists are getting, I suppose they get, of course, training in malignancies in the oral cavity, and but in general, they come through head and neck specialists, including surgeons. So dentists can also refer these patients, yes. But then they refer it to surgeons who are experts in this area.
Yes, but is it a relative question to bring it up in their awareness by the dentist?
Maybe I can help because I'm a bone oncologist and I have a twin sister and she's a dentistry. So we just recently discussed.
I have a daughter that is doctor and a daughter that is dentist. So I want to bring it home.
Okay. So I think they don't have a specific training of osteosarcoma of the jaw, but they do know that malignancy of any kind might happen. So anything that doesn't go away within the first few days, they would refer for biopsy.
Okay,
they told me like that. But not all of them, because we see gigantic jaw osteosarcoma, so you're right, it's a very good point.
Thanks for the presentation. I think you could speak for another 2 hours and we'd still be learning, so thank you. My question is in relation to the transition from pediatric to adult system for AYAs. Do you think there's an optimal age, or based on your last slide, do you think it depends on the subtype as to when the pediatric oncologist would step back and the adult take over?
Well, what we know from Europe is that there's a big difference between countries in how this care of this age is organized. Like in the UK, there you have the teenager and the TYA units, and that goes until the age of 24. But beyond 25, it's, I think, the same issue as everywhere. In the Netherlands, we have the centralized pediatric oncology until the age of 18. So they are all seen in Princess Maxima Center. That's totally centralized. And beyond that age, they are sent to all adult specialists. So it's really, you have to be proactive to organize it. And I know it's for different countries in whole Europe different organized. And that's also one of the topics of an AYA, the strong AYA program that we run through EU as an EU project now in 5 different countries in Europe to see where AYA care and how it's organized in the different countries in Europe.
Okay, thank you, because I think that's something we're looking at here. It's currently 16 in Ireland, and there's talk of maybe 18 might be more appropriate for that pediatric support. So thank you.
Yeah.
I have a question. By collecting real-world data, clinical registries are crucial in order to better understand what happens immediately and in the mid to long term, and how patients perform in different age groups. Which are the main obstacles for the adoption and implementation in a systematic manner?
That's a very good question. Well, interestingly, that's also part of this project that we run through EU on AYA, because what we aim to do is, of course, collect all the data of patients, but not in a way that we need extra workforce, because that's so difficult to get people at the moment, and there is no budget for it. So there is a way of what we call federated learning, where the data sits in the hospital, and where ideally you get these data out and you can just ask a question to the different centers who participate in this federated system, like you have your sick ducks patients, and then you can ask the questions and you get it out of the system without having to build a registry for all 100 different sarcoma subtypes. And that's, I think, the horizon where we are working towards, but that will take a lot of time and effort and hospital IT stuff and people who can do it. But I think once we are able to do it for one disease, it should be, doable for another as well.
Thank you so much. Other questions? No. Wow. Thank you, Professor. Now I'm pleased to welcome Dr. Palmerini, who will provide us an update about research on osteosarcomas and Ewing sarcomas.
Thank you to SPAGN for the kind invitation. I have to disclose which is my first patient advocacy conference, and I'm really, really happy to be here with you today. I've been working with bone tumors since almost 20 years now, and I had the opportunity to work together with Dr. Bacci. We started to do chemotherapy with methotrexate together with Jeremy Rosen in New York at the same time. And but today, Paula asked me to talk about some updates. So these are my disclosure. And first of all, doing progress in bone tumor research is really hard because they are extremely rare, as we discussed. 2 per million per year if we consider osteosarcoma of all age, and only 0.1 per million per year for Ewing sarcoma. So if we consider that last November we hit the 8 billion mark, so there are roughly 8,000 Ewing patients per year, which is not an easy number to come out with great clinical trials. On top of that, the genomic is really challenging and quite opposite. Osteosarcoma has a complex karyotype, genomic instability, and events such chromotripsis and ketogenesis happens, which are difficult to explain, but is DNA in some specific spot, it's really disrupted, and there are very few mutations. While Ewing sarcoma has a simple karyotype, there is this pathogenetic translocation, but there's a large heterogeneity also at methylation level and the lowest frequency of somatic mutation, so different to target. And where we are, so with the standard chemotherapy approach, and the drug approved for osteosarcoma are methotrexate, cisplatinum, adriamycin, and the survival at 5 years for localized disease is almost 80%. In that trial, on the left, we also used mifamurtide in a high-risk patient, meaning P glycoprotein positive. For Ewing sarcoma, there is nowadays the evidence that's compressed over standard chemotherapy should be used. Compressed means chemo every 2 weeks instead of every 3 weeks, which is quite tough and can be done in every patient, can be done in pediatric patient and in some of the adolescent and young adult, and sometimes it is still challenging. The field where we are totally unsatisfied is the metastatic setting. No matter how research was pushing over years, this paper 2003 from the German group is still 5-year overall survival, about 30% with patients without metastasis. And similarly, in Ewing sarcoma, you can use also transplant or fancy non-toxic drugs like triosulfan. Still, the survival at 5 years is only about 30%. Means that after 5 years, 7 of our patients are falling to these diseases. So I wrote with the pediatric oncologist in the United States, did editorial to stress that we really need to change and to have new drugs in this tough disease, which is also not a unique disease. I did my PhD together with Professor Pileri, which is an important lymphopathology, and we observed that a tumor microenvironment is important. The bottom line is they are all osteosarcoma patients localized, treated by the same surgeon with the same chemo, but you can see when there are no CD8 TIA1, which are the bad lymphocytes, so the lymphocyte that promotes immune response, the survival is much lower as compared to those that have an active immune infiltrate. So we treat this patient differently. And this the last year, this multi-omic study, which because now we have the speediness of genomic helping us, so through epigenomic and transcriptomy, 121 patients were classified, and as you can see, there is that curve, purple curve, which is the MYC-driven osteosarcoma. It's a group of sarcoma that definitely does much worse. So the point is, not only we should have different drugs, but we should also probably treat them differently from the beginning, very similar to what we are always doing with leukemia. And I was struck the last CITOS to find out that sequencing our patient, we also find out that some of them are not even osteosarcoma, there are other diseases, like both two studies, one from UCLA and one from Lund University, they both found that roughly 2.3% were reclassified, and there were like FOS and FAT C2 or FOS and FAT C1. So the classification problem will help us to drive a clinical trial much more accurate in the future, and probably we should sequence all of our patients to understand better the biology. In Ewing, it is very similar. There are STAG2 mutated and STAG2 combined with PCR mutated, which has a different and very different survival. So again, should we treat them with different approaches? This data has been there forever and has been recently confirmed by the Kaugo group. And also, at Rizzoli, almost 2,000 Ewing and Ewing-like cases were re-reviewed, and as you can see, we found that 1.27% were chick ducks, for 0.8 were B-core, and again, all those very rare entities. So if we look at them deeply, we found different diseases. So if under the microscope all these tumors looks alike, after sequencing we found totally different disease. And I really like this Linneo comment that if you do not the name of things, the knowledge of them is lost too. So I think this transition, so sequencing our diseases and naming them, is really, really important for the understanding of their prognosis and their eventually treatment. For this reason, a few years ago, we started this project. It's called Graceful. I really like the name, Graceful. It's a global collaboration on Ewing-like sarcoma involving people from all over the world. And we were able to confirm on a large series that survival for B-core is very good. At 3 years, 92%, while chick rearrange was only 39%. And unclassified, so those that remain with no translocation, is about 78%. But let's go back to the question of Dr. Gonzato for today. So the $1 million question. There are new treatments that really change this survival, or will change the survival in the near future for bone sarcoma. And my answer is unfortunately not yet. And there were a lot of hope in cancer treatment starting in 2013. This is the Science paper, and cancer immunotherapy was defined in 2013 the breakthrough of the year. And as you might know, the drug are the most used drug are immune checkpoint inhibitor, which blocks that PD-L1. So they block the crosstalk of our lymphocyte with our antigen presenting cell, those actors in the immune microenvironment that may attack the tumor. So which is the problem in bone sarcoma? The tumor mutation burden. So tumor immunoresponsive like melanoma has a tumor mutation burden of 400. In lung cancer, the threshold to respond to immunotherapy was set at 10. As you can see, here it's really depressing. There is a pediatric paper of Nature, osteosarcoma is 0.79. So we go from 400 to 0.79. And similarly, in this recently published study from Memorial Sloan Kettering, is still in adult 2.5. So very, very unlikely to respond. And we have the confirmation, sadly. All the clinical trial, as you can see, the overall response rate with bemprolizumab, nivolumab, or nivolumab combined with ipilimumab, it's it's 0 or super low, and also the duration of response is really less than 3 months. So we also talk that we can stimulate the immunomodulation. As you know, there since 2018, another big weapon against bone sarcoma are the tyrosine kinase inhibitor. These drugs are approved for kidney cancer and a lot of other tumors, and have been studied in bone sarcoma with some improvement in progression-free survival. They are very different one among the other because they target all these different receptors: vascular endothelial growth factor receptor, or platelet-derived growth factor, or fibroblast growth factor receptor. So there are some reasons that some work a little bit differently, but still the response in monotherapy are very low, and also the combination of checkpoint inhibitors, so immunotherapy, and anti-angiogenetics led to very few response. 20% in a Chinese study, and only 5% is in this European study I presented at ASCO. This is the study from the Spanish sarcoma group, the JACE. So you give the anti-angiogenetic for 2 weeks in the hope to immunomodulate, and then you combined with the immunotherapy. Of course, we took biopsy pre and post to see the modulation, if the modulation was really happening, and there's analysis ongoing. What we have is the response. So there were 17 osteosarcoma patients and just 1 partial response, and there were 8 Ewing, 0 response or dimensional, and the median progression-free survival is 3.7 months. So that this is certainly something that cannot change the paradigm in bone tumors. And the second very important question: can we use CAR-T? Just this month, this New England paper came out, and it is a different disease, is neuroblastoma. In neuroblastoma, it's the first paper with this approach in solid tumor, and as you can see, the response was really good, 63%, and also the cytokine release syndrome, which is one of the main concerns of this treatment, was in 74% of the patients, but we now have this SUI-SID gene that might take this treatment much safer. So what is CAR-T? CAR-T is a combination of a monoclonal antibody and T-cell receptor, so it's chimeric antigen receptor, so-called. The most important things is that we have the right target for this disease. And there are several targets in bone tumor that from preclinic to clinic were investigated over time. The first was HER2, and the first study with CAR-T against HER2 was published in 2015. Unfortunately, the median survival was 10 months only, and the author concluded that this approach was safe, and so that these CAR-T were able to persist 6 weeks, but 6 weeks is still not enough. Other target, GD2. GD2 is very famous. It's an antigen membrane called surface ganglioside that, as you can see, it's very highly expressed in osteosarcoma. In Ewing, some paper say 20%, some 40%, so maybe a good opportunity in bone tumors. Again, last year, this dinutuximab, which is not a CAR T, but is a drug that can attract lymphocytes, so immunomodulation, was studied in recurrent osteosarcoma, and the author conclude that was not dinutuximab adequate to improve outcome in relapse paper. And the problem is not the lack of the target, as you can see, you saw the target is there, but there is probably a not sufficient activity of the drug. Last target is probably the most interesting, B7H3. You should remember it. It's, what is that? Again, it's something that mediates the interaction in between T lymphocyte and the antigen presenting cell. It is also called CD276. Is this target relevant in bone sarcoma? Of course, 92% positive immunohistochemistry, osteosarcoma, and almost 90 Ewing sarcoma. And this nice research from the Stanford group, Robert Meissner, showed that combining CAR T targeted against this B7H3, not only the tumor shrink, but the survival improve significantly. But this is preclinical. In the clinic, we are still to face a lot of important problem. First, tumor heterogeneity, and second, the fact that bone sarcoma are immunocold and also harbor an immunosuppressive microenvironment. So can we have some hope for the future? Maybe there are also macrophages there in the tumor microenvironment, and we have drug that can target macrophage, and especially CD47. CD47 is a don't eat me signal. So as you can see, the circle yellow is the tumor, and those pink bed is the macrophage. So this antibody, the CD47 antibody, can inhibit this don't eat me signal. So the macrophage is suddenly in the power to eat the tumor cell. And again, this pediatric branch at Stanford combined the anti-GD2 and the anti-CD47 in the mice, and the mice always, they work perfectly, and the synergism is brilliant. So we hope that in the future, all this preclinical evidence will translate in activity. For now, we can relay in genome information, and there are also a lot of genome match trial in pediatric oncology. What is the meaning of this trial? That you study the genome, you found some pathway, and you have the PDX, patient-derived xenograft. So you have model where you can actually use the drug before using in the patient. And for example, in the MYC alterated osteosarcoma, those with bad prognosis, 519 was used with success. In fact, there are a number of MYC-oriented drugs. The problem is their therapeutic window, but possibly in the future this will improve. So we won't have a bunch of patients with osteosarcoma. We will have our MYC-positive osteosarcoma and all other. And I want to end with one of my patient discussion with you. This was a young boy of 11 years with a Ewing sarcoma. As you can see, this is his MRI with there's uptake on his left femur, and also he had a tiny lung metastasis. He underwent standard chemotherapy, and the response on the soft tissue was almost complete, and our super surgeon did the resection and the biological reconstruction. And the problem is that this patient he came to our clinic in 2007 and also did that autologous transplant. He relapsed in 2013, and he did a number of second-line treatment, as you can see, temozolomide irinotecan, gemcitabine, taxotere, fosfamide high dose, and so on. He also participated in a clinical phase 1 clinical trial with epigenetic DS1. All over this time, he underwent a large number of surgery for fracture, non-union, also a pneumonectomy in Milan, because sometimes surgery seems the only opportunity, and there are, if you look for a surgeon, you always find a surgeon, and I think it's a very important problem, and also the radiation therapy. So a very difficult life. And do we think that he would have better drugs, better chance today? I don't think so. There is some excitement around this K216, but still only 2 patients responding out of 23 patients, and the update of the study confirmed only 2 patients out of 35. So again, preclinical activity is striking, but we might be more happy with the combination of this drug with chemotherapy in the future. And there are a number of phase 1, phase 2 CAR-T trial in the Ewing, and also in Italy at Bambin Gesù, and we will see. And there are also preclinical evidence that AZH2 inhibition might be synergic with GD2, but again, this is super experimental, so I'm not sure about my patient. But I want to share with you his major concern. So the major concern of this patient, we all love this guy. He was concerned about his job. So due to the long hospitalization and the surgery, he was always worried about that. And in this picture, you can see our president, Sergio Mattarella, and Steven, the patient. And the couple in between is the couple that own the firm where Steven worked. So they decided to keep him on salary no matter how he was working or he was receiving treatments, because they didn't care. They wanted to be better person. And I think that our patient, this should be taken seriously into account. I don't want heroes. I want a normal life where there is a respect not only of the disease, but also of the patient, that in the age in between 15 and 40 should try to live possibly a normal life, especially if he wants to. So to conclude, we probably are all going from a multidisciplinary team discussing with surgeon or radiotherapy, with the multidisciplinary molecular tumor boards, where we also take into account molecular information, but the most important, to have a success treatment of our patient, we should consider him as a whole to be really happy. This is my son last Christmas, so he was completely happy. But I think that considering work and sexual and reproductive health, and also survivorship, so consider active surveillance and the importance to go to the gym, as well as early palliative care when it is needed. Of course, to do that, we have to collaborate with, of course, Foster, Euro Ewing, Cellnet, URTC, and as I said this morning, pediatric and adult, and also patient advocacy group that might support the development of new drug with our regulation, and of course the people working in the hospital, but also those in close to the patient home. And all this process is very tiring. Sometimes what we see is the top of this podium, but behind there is a lot of frustration and fatigue, and so I think that it's only through the supporting each other that we can eventually improve the life, the combined life, so quality of life and duration of life of our patient. And I want to thank Professor Campanacci for his great mentorship. This is Istituto Ortopedico Rizzoli in Bologna, our library, the new building for the phase 1 treatment, but that most important is something that is written on our corridor under Professor Campanacci. So the first line is patient at center, in you since the beginning, and of course meritocracy, international relation, because to build something meaningful in rare tumor, we need certainly all of these important things. And I want to thank also all my collaborators at Rizzoli, because I think that it's just through the working with your team as a family. Since you spend so many hours, you eventually achieve something, and you are able to face all the challenges. And I thank you for your attention.
Thank you very much for this great presentation. Are there any questions? I have a question, of course. Focusing on immunotherapy, in particular on adoptive cellular therapy, one of the main concerns are side effects. Are there any clinical trials to evaluate, to assess these issues, in particular neurotoxicity and cytokine storm?
Yeah, so there are several trials in liquid tumors and in solid tumor non-sarcoma. So now the treatment of cytokine release syndrome is much improved, but I still remember discussion from colleagues from Memorial Sloan Kettering, and Sandra D'Angelo running the first phase trial was always at the hospital, because the number of patients that suffered such side effects is extremely high. Luckily now they are quite, the severity is quite mild in most of the clinical trial, and also we have this suicide genes that you can inject in the patient when the immunoreactive response is too bad. For the neurotoxicity, a good example is the nituximab. The duration of the treatment has been an important change. So they went from 4 hours to 48 hours, so long infusion reduce enormously the neurotoxicity of the nituximab. So I think that collecting all those information on toxicity and maybe combining those agents as in the preclinical model from Stanford, so BH7 and GD2, we might hope to have a game changer also in osteosarcoma, for example.
Okay, thank you. I have another question. Talking about CAR T cells and their adoption in osteosarcomas, which are the main limiting factors, antigen selection or tumor environment, or both of them?
Yeah, I think both probably, and Again, the preclinical model showed excellent result both with GD2 and B7, but the clinical research on is still ongoing. So, and I think that in the future, combinatorial approach might be required in the field of bone sarcoma, but we will have soon the results of all these clinical trial I showed, and I think that we can certainly build from that and from the preclinical research. But mainly, I think, she will talk about Foster, the most important is the patient stratification that we will reach only through a deep learning of that specific patient biology very early in the course of this disease.
Okay, thank you so much. Any other questions? No. Well, it's my pleasure to welcome. It's my pleasure to welcome Dr. Jasmine Oz, who share with us the early results of the survey, of the Foster survey. Foster is the European Consortium for Fighting Osteosarcoma through Research, and the Foster survey has the aim to gauge the experiences of the patients, carers, patient advocates, and to help inform the future direction of research. Please, Jasmine.
Thank you so much. So I'm talking today on behalf of the patient parent group of Foster. I know there's a few other members here, Ornella, and we've also got Angelica in the crowd as well. And there might be someone else, so wave at me as well if you're part of that group. But I'm going to today be talking about Foster and the first global survey on bone sarcoma. So once the slide moves, there we go. So first of all, introducing Foster. So Foster is fighting osteosarcoma through European research, and it's a dedicated osteosarcoma consortium with over 265 members across 19 European countries. We can really hope to accelerate research into osteosarcoma through collaboration and ultimately improve outcomes for people with osteosarcoma. So the way Foster is structured is it's got 8 work packages, and some of those work packages focus on more fundamental research, so really trying to understand how osteosarcoma occurs, how it metastasizes, and through that we are looking at developing preclinical models and really understanding the genetics of the condition. There are also more translational work that's being done, so we hope to kind of start developing trials, both looking at osteosarcoma in the relapse setting, but also thinking about first-line trials, because we know that different countries in Europe do use different first-line treatment. So that's something we also want to explore. As was mentioned earlier, we also are focusing in on the importance of looking at the long-term effect of treatment. So we're not looking just at patient's journey from the beginning, when they're first diagnosed and when they're initially treated. We want to look at the long-term effect of that treatment and their quality of life. So to ensure that what Foster is doing is meeting the needs of the community, one of the first things that Foster did was to make sure that there were patient representatives within Foster, and they set up the patient parent group. So the patient parent group is actively involved in Foster. It consists of patient parents and patient advocate groups, and they have their own group within the organisation. But in addition to that, each work package has a patient representative, so they can actively get involved, talk to clinicians, talk to researchers, and really make sure the work is being done is in the best interest of the patient community. However, to start with, the patient parent group didn't want the work that's being done within Foster to be based solely on one small group. They really wanted to reach out to the wider osteosarcoma community and get a better idea of their treatment journey and also what they think should be prioritised in terms of support and research moving forwards. And so that is when, as a group, we developed the first ever global bone sarcoma survey. So I've been speaking about osteosarcoma here, and Foster is dedicated to osteosarcoma. But when we put this survey together, we decided to open it up to all bone cancers. There were a number of reasons for this. One, just if we were going to be doing such a big survey on an international level, it was an opportunity to extend it to more people. But also from talking to different groups who'd ran surveys before, they explained that people who don't have osteosarcoma but may have other types of bone cancer may also take part in the survey anyway, and therefore it made sense to include them. So the purpose of the survey was, one, to identify where disparities lie between different individuals and different countries, to shine a light on the differences between sarcoma subtypes and variations across ages, and also to assess the experiences of patients and parents, and, as I've already alluded to identify research priorities. We've got this lovely logo for the survey, which was designed also by members of the patient-parent group, and it's got all the different types of bone tumours on there. So the survey asks multiple questions, and it focuses on diagnosis, so not just about someone's diagnosis experience, but whether they were misdiagnosed, where they got diagnosed, whether how long it took them to get diagnosed as well. It then focuses on treatment, asking about the treatments patients actually received, but also whether they were involved in their treatment decisions, so it asks questions about shared decision-making. It then focuses on support, both from the support that they got during their cancer treatment, whether that was the support they actually would have wanted, and what support they got long-term. And finally, it also asks questions about research priorities that I'll be going into in more detail later on in this presentation. The survey is currently available in 6 different languages, and again, this has all been translated by members of the patient-parent group, and the languages include English, Dutch, German, Spanish, Italian, and French, and it will be opening up in more languages very, very soon, which is very exciting. So I'm now going to move on to some of the early results from this survey. A few things, none of this data is published, so please don't share it outside of this, don't post it on social media. Additionally, this is just the raw data, and we're still collecting data, so some of these results may change as more people complete the survey. And it's been open for about 6 months at this point. Done, then we can go and have lunch. The next steps are, first of all, the survey is soon going to be launched in Norwegian and Polish, which is very exciting. Again, that means we can get a wider reach and make the survey more accessible to more people. We want to continue to recruit people to the survey, and then when we finally close the survey, the aim is to get the data published and then feed that data into research, not just the Osteosarcoma Consortium Foster, but feed it into other research groups as well. So now I'm handing it over to you. What can you do? When we put this survey out, a key question was asking how people heard about the survey. And the majority of people heard about this survey through social media. So that was about 50% of individuals who completed this survey. A small number also heard it through patient advocacy groups, and some also heard it through their doctors. We want you all to keep on sharing this survey via social media. I meant to put the link to the page about it below this graph, but I haven't. But if you go onto the SPAGN website and go onto their news section, you'll be able to find all the details of this survey and the links to the different languages. However, we can't expect just to reach people on social media. We know some people don't use social media, and therefore it's also important to have different routes. So I would encourage you to either add it to your blogs or your newsletters, just to tell more people about the survey. In addition, we have created some leaflets about the survey that can be given to doctors who can then hand it out to their patients. So that is another important route in order to reach more people and potentially new people who are in there being diagnosed. So the final thing to say is thank you. I've got a few thank yous. So firstly, thank you to the patient-parent foster group who've done an amazing job putting the survey together and making it a reality, and also for being so well integrated into foster as well. It's so important that when you have big consortiums like this, the patient voice is heard from the very beginning, and that's what foster is doing. So thank you. I also want to thank a couple of the patient advocacy groups. So the survey is hosted by the BCRT, so thank you so much for that. And also SPAGN have got a wonderful thing about this survey on their website, so please check it out. And finally, thank you to everyone who has completed this survey. All this data that we are collecting will go in to inform future research and improve outcomes for future patients. So thank you so much. Any questions?
Thank you very much, Jasmine. Are there any questions? I have not a question, but just a comment about the low interest on drug repurposing. It doesn't surprise me because last year we at SPAGN have a session on drug repurposing, and after our session we launched a survey on for assessing the interest from the patients on this issue, on this topic. And the interest was low. Drug repurposing is the strategy to identify new uses for all drugs. It has the potential to reduce time frames and decrease the cost of development of new drugs. But why should the drug repurposing, why should patients be interested in drug repurposing? Because bone sarcomas in particular are rare cancers that still have limited treatment options, if any at all. And they are orphan drugs and financial orphans due to the limited commercial interest. So this is a topic on which we need to improve information and education because it's very crucial.
100%.
Do you have any other thing to add?
No, I think everything you said just then about drug repurposing is so true. And I think, again, this is a place where patient advocacy groups can step in and help with those conversations moving forwards. And I think we've got this data now, we're getting it. And I think the next thing is to do further conversations with people to really understand the answers.
Okay, thank you. Questions? Just a few words. Thank you, Jasmine. Just two words in order to conclude this session. We can say many challenges are still to be faced. This is the reason why it is crucial to build a strong bone sarcoma community. And this is exactly the meaning of the Bone Sarcoma Alliance under the umbrella SPAGN that we launch in shortly, in order to empower interactions among patients and better involve them in the dialogue and cooperation with clinicians and experts to accelerate the research progress. Thank you all, and we have lunch, of course.